Yeah.
Sure. Okay, good afternoon, and welcome to the session in Update in Hospital Medicine. I'm Stephen Cohn from the University of Miami Miller School of Medicine, and my colleague.
I'm Nick Fitterman from Northwell Health, formerly North Shore LIJ.
And as you know, this session is sort of a summary of a review of the literature from the previous year, and what we try to do is come up with clinically relevant articles that are very good for the practicing clinician. Now, unlike a couple of years ago when the presenters came running on stage dancing to rap music, and last year when people came on stage in shorts and Hawaiian party shirts, this year, no shtick. Why? We want to make SHM great again. This meeting is huge. Okay. Now, not many of you know, Nick and I are both originally from New York, and this is from the New York Times over 10 years ago, and Nick was willing to see patients if they paid a $1,500 retainer. The doc will see you now. And back then, this is what Nick looked like. And here's his car. But he thought better of it after a few years and said, I can't take this anymore, I have to become a hospitalist. So now this is what Nick looks like. And there's his new car. Okay. Again, as I said, we're both from New York. This is a recent picture from Times Square in the last snowstorm. And if you look at somebody shoveling snow back there, you can't really see, it's a little fuzzy. Oh, that's Nick back in the winter shoveling snow. But about 5 years ago, I thought better of it. I had been in Brooklyn working for a long period of time at downstate in Kings County. And I said, time to get out. I'm leaving. Forget about it. And I went down to Miami Beach, where they welcomed me with open arms. And while he was up there shoveling snow, I was at the University of Miami, living the life, and he's shoveling snow, I'm on the beach. So, all right, no more shtick, that's it. So how did we come about doing this presentation? And I'd like to thank the people who supported us and recommended us to do this presentation. These are the methods to our madness. We reviewed SHM, the Hospitalist, and other related publications. We did a few quick topic literature searches, like for stroke and pneumonia. We excluded perioperative medicine, which is actually my area of expertise, because there will be a separate session on that tomorrow morning. We asked our colleagues what they thought the articles were that we should be covering for the presentation today. And being evidence-based, we developed an elaborate scoring system to rate the articles. We had two experts with over 50 years of clinical experience decide what to present. You go from dark hair, gray hair, white hair, and no hair. That's how you get experience. But the bottom line is we just picked out what we thought was important and clinically relevant to hospitalists, and we hope you agree with our selection. And with that, I'll turn it over to Nick.
All right, thanks, Steve, I think. But anyway, so disclosures. I have no financial disclosures, but I do have to tell you I chair the test writing committee for ABIM for CERT and maintenance of CERT. No questions will be revealed today. If you want to talk or yell at me about MLC, we could do that afterwards. The real disclosures, I'm not an expert in anything but merely a journal junkie. I stole that line from Danielle Schurer when she did this update. And Steve and I are going to give you a little more breadth than you used to at these sessions with maybe not as much depth. There are a lot of articles we want to cover, but we can dive in as deep as you want in the Q&A sessions. Another real disclosure, I wasn't always bald. I had a lot of hair, but unfortunately decided to go to medical school. All right, let's jump in. First case. By the way, we're going to give you cases. Throw your hands up in the air as many times as you want on the questions because there's more than one right answer on each slide. 66-year-old female. She has a history of diabetes type 2. She presents with cough, yellow sputum, fever. She has a temp of 101, heart rate of 90, respiratory rate is 24, and take note of that. Your exam and your chest x-ray confirm your clinical suspicion of a left lower lobe pneumonia. Laboratory data reveals a white count of 13,000, 12,000, BUN of 22. So being an evidence-based hospitalist, you apply a validated clinical prediction rule. Most of us will use CURB 65 because it's easy. Help you to decide whether she gets treated and treated, admitted to the medical floor, or admitted to the ICU. With her score of 2, she is going to the medical floor. In addition to antibiotics, fluids, supportive care, which of the following can you offer to improve outcomes? Okay, does anyone want to give this woman high-flow oxygen via a nasal cannula? Any hands? All right, I got a few hands up here. These guys are smart. Anyone want to give non-invasive positive pressure ventilation, the NPPV? Not an audience response system, just throw your
You need
hands.
some voting. Raise your hands.
How about mucomist? Anyone want to give N-acetylcysteine? And finally, prednisone. Anyone want to give prednisone? Oh, this is an avant-garde audience, Steve. We're in trouble. All right. So we put this article in, as you probably all know. This is a meta-analysis in the Annals in August. And they looked at steroids in treating community-acquired pneumonia. And now, this is not a new topic. There was a Cochrane review in 2011, did not find enough robust evidence to recommend its routine use. The authors here use the same methodologies that the Cochrane review has used, but they updated it up to and including the 2 articles published in 2015 in JAMA that you're probably familiar with. And they came to a bit of a different conclusion. So this is a forest plot of the impact of steroids on mortality in CAP. So if it's to the left of the line, it favors steroids. To the right of the line, it does not. If it crosses that line, 1, the confidence interval crosses 1, then it's not statistically significant. And you can see here the impact on mortality, it just touches 1, but the point estimate seems to favor a reduction in mortality. Well, what about the impact on the need for mechanical ventilation? Here you can see it clearly favors steroids. What about progression to ARDS? Again, favors steroids. And something near and dear to our hearts, how about impact on length of stay? Favors steroids, reduced it by 1 day. So it led these authors to conclude the following outcomes, positive outcomes, with this level of certainty of the evidence. Now, because it was in 2016, we didn't include it, but January, Chest published another meta-analysis of the same topic, came up with the same conclusions, except they did not recognize a mortality benefit. So is this ready for prime time? Well, the authors of the Annals meta-analysis and systematic review appropriately caution us that the mortality benefit was driven by 1 smaller study stopped early for efficacy. They also appropriately call out that the largest benefits seem to be in those that had SCAP, or severe community-acquired pneumonia. They also call out the dilemma in what dose and what duration. In that meta-analysis, the duration of steroids went from 1 to 10 days. We included 2 doses here from the 2 most recent studies. But keep your eyes out for the ESCAPE trial. This is a large trial, over 1,400 patients in the VA system, that should answer, hopefully, all of these questions with results later this year or early next year. This is a slide just to remind us that to define SCAP, severe community-acquired pneumonia, there are actually criteria published by the IDSA out there to help you with your gestalt. I'm not going to go through all of them now. It'll be in the slide decks available to you. All right, now 24 hours after she's admitted, she gets worse. She becomes more hypotensive, more hypoxic, more tachypnic. She is going, and the chest x-ray starts to blossom and look like ARDS. So she's going from sepsis to severe sepsis and septic shock. And that happens in at least 12% of patients, or up to 12% of patients, that have even just 1 SIRS criteria, also published in 2015. So clearly we need better markers to identify these patients at risk to progress from sepsis to severe sepsis, septic shock. And that respiratory rate of 24 may be the best one that you had in this case. And by the way, I know what the real up-to-date hospitalists are thinking here, Steve. They're saying, he said severe sepsis, and the sepsis 3 definitions were just published, and severe sepsis is gone. Well, recognize that isn't accepted by everyone yet. You'll have to come to the update in Las Vegas in 2017 to see where that falls out. All right, back to our case. She's developed severe sepsis, septic shock. What do you want to do now? Who wants to give IV crystalloids, 30 mLs per kg? Right, everyone should be putting their hands up. How about, does anyone want to give non-invasive positive pressure ventilation now? NPPV. Couple hands, okay. How about high-flow oxygen by nasal cannula? Man, these guys are good. These guys are good. All right, so this is one of the game changers, the Florali study published this year, which it looks like a lot of you are already familiar with. High flow oxygen through nasal cannula in acute hypoxemic respiratory failure. So what is high flow nasal cannula oxygen? The nasal cannula is a little bigger than the nasal cannula you're used to seeing, and it delivers a high concentration of O2 at 50 liters per minute. And while it doesn't blow the nose off one's face, it does create a little bit of PEEP. It reduces the dead space of breathing. It increases CO2 excretion, and it's more comfortable than the tight-fitting masks. So Florali randomized 310 patients with acute hypoxemic respiratory failure. Most of them had pneumonia. They excluded chronic respiratory failure. The COPD or CO2 retention were excluded. And they randomized them to standard oxygen, just a face mask, NPPV, non-invasive ventilation, or the high-flow oxygen. They looked at need for intubation and mortality at 90 days. And here's what they found. The top graph shows need for intubation, so lower is better. And the high-flow oxygen group did the best. 38% required intubation versus 50% for the non-invasive ventilation. But that didn't quite achieve statistical significance. The bottom graph was a post hoc analysis where they looked at the 238 patients that had the most severe hypoxemia. That did achieve statistical significance. And look at the mortality. Here presented as cumulative probability of survival. So here, higher is better. High flow oxygen wins again. These findings were statistically significant. And what's of interest here, look who lost. NPPV, non-invasive ventilation. This had been standard of care up until now. The authors postulate the reason for this, that NPPV provides 9 mLs per kg of tidal volume. That is not the lung protective strategy of ventilation that is suggested in ARDS and sepsis. So you're snapping open those alveoli, they slam shut, you perpetuate the cytokine creation that propagates sepsis. So what does this mean, putting it into practice? High-flow nasal cannula oxygen may be of particular benefit to those receiving palliative care, easy to talk and eat, more comfortable. It appears safe and effective for acute hypoxemic respiratory failure. Remember, they excluded COPD, chronic respiratory failure. And it's a lot cheaper, less than $100 a day versus $1,000 a day. Speaking of oxygen, and this is a quick hit, a one-slider. Speaking of oxygen, it's a drug and should be considered such. I do clinical work at 3 hospitals over 25 years now. I've never seen anyone admitted to the telemetry unit or the CCU that didn't come up with nasal prongs on, regardless of what their O2 sat was in the ED. And it turns out there's some recent physiological evidence indicating that oxygen may be harmful. It may actually decrease coronary artery blood flow by increasing coronary artery resistance in some beds, and promotes the production of free oxygen species. So thus the AVOID trial. And what the AVOID investigators did is a multi-center trial. They took 441 patients with an acute ST segment elevation MI. They had to have an O2 sat of at least 94%. They randomized them to oxygen by nasal cannula or room air. And what they found is there was no difference in time to relief of chest pain, no difference in the hemodynamics. But there was a signal, there was evidence that the MI may be bigger in those that got oxygen. The oxygen group had more arrhythmias, they had a higher peak CPK, and on a follow-up cardiac MRI 6 months later, they had a larger infarct. So this is a drug, oxygen, that doesn't help here and may harm. Why are we doing it? In fact, it's worked its way into your 2015 updated ACLS guidelines, where the authors now say in an acute coronary syndrome, in a normoxemic patient, you can choose to withhold or avoid, pause for effect, giving supplemental oxygen. I don't think anyone got that one, Steve. All right. Next case, 65-year-old man with type 2 diabetes, hypertension, hypolipidemia presents with 4 hours of right arm weakness and aphasia. He has an acute ischemic stroke. He's on aspirin, lisinopril, metformin, and atorvastatin. Which of the following can improve functional outcomes and reduce his risk of another stroke? All right, does anyone want to give IV TPA? He's in within 4.5 hours. IV TPA, standard of care. Intra-arterial TPA. Endovascular therapy. All right, we're losing him. Clopidogrel, so here it is. 8 studies on one slide. Strap yourself in for this one. So go back to 2013, only about 2 years ago. IMS-3, Mr. Rescue, and the Synthesis Expansion Study were all published in the same issue of the New England Journal of Medicine. They compared intravenous TPA in acute ischemic stroke to intravenous TPA plus endovascular therapy. Every one of those, and these were high-quality studies using the latest and greatest imaging, the latest and greatest endovascular devices. They showed no benefit. It turned endovascular therapy on its head. Fast forward to 2015, we have 8 more randomized controlled trials showing benefit of endovascular therapy in acute ischemic stroke. These are the big 5, all published in the New England in 2015. Mr. Clean was the first one to come out. And after that benefit, the other 4 trials did an earlier than anticipated interim analysis of their data. And the results look so good, they all stopped their studies early for efficacy. I'm not going to go over them in detail. I'm going to give you kind of the summary of the common themes here. So they were all randomized controlled trials, acute ischemic stroke. They were randomized to usual care, which was IV TPA within 4.5 hours. Usually they got it within 2 hours, versus IV TPA plus endovascular therapy with a stent retriever. There were some variations in the time allowed to implement the endovascular therapy. 3 of the 5 did it within 6 hours, 1 within 8, 1 allowed enrollment up to 12 hours. There was also some variation in the imaging they used. They went from trying to define the ischemic penumbra mismatch with CT or MR imaging using something called a rapid software, and or something called the ASPECT score, which stands for the Alberta Stroke Program Early CT score. And that's a score from 0 to 10. And it defines the size of the core infarct. The higher the score, the smaller the core infarct. And it looks like the most robust evidence for benefit were in those with an ASPECT score of greater than or equal to 6. They all looked at functional independence at 90 days. And if you do the math here, the absolute risk reduction was 13 to 31%, with a number needed to treat of only 3 to 7 to benefit with endovascular therapy. So how did they get it so wrong just 2 years ago and so right now? They took a page out of the cardiologist handbooks on quality improvement, and they got their door-to-groin puncture times down to under 90 minutes. This new stent retriever technology allows swifter and more complete recanalization of the infarct-related artery. And finally, and probably most importantly, they picked the right patient with their neuroimaging. They had to prove that there was a clot in the large anterior vessel. The ICA, or the M1 branch of the MCA, is where the largest benefit is. And they had to have a small core infarct, 50 to 70 mLs as judged by the ASPECT score, because that probably means there's good collateral circulation. So this evidence was so robust that it led the AHA and the ASA to do a focused update on their practice guideline for endovascular therapy in acute ischemic stroke that they had just done in 2013. And they now recommend endovascular therapy with a stent retriever for acute ischemic stroke for patients fitting these criteria. And we mentioned most of them already. I want to call another one out. The symptom onset to groin puncture has to be within 6 hours. The data was not robust enough for the 8-hour and 12-hour group. In addition, the modified Rankin scale score before the stroke has to be 0 to 1. Modified Rankin scale goes from 0 to 6. 0, you're fine, 6, you're dead. So before they got the endovascular therapy, before they had their stroke, they were pretty well-functioning patients. So we don't want to send our patients with functional disabilities, our dependent patients, for this. Not yet, anyway. And notice I didn't mention age, because they enrolled older patients in this. The oldest patient was 92. Steve.
Okay, thank you, Nick. All right, we're going to continue on with the same patient and show what can happen, what can go wrong, and all other complications the patient can have. So the patient's workup for a stroke is unrevealing. It's a cryptogenic stroke, but a Holter monitor is placed, and it picks up paroxysmal atrial fibrillation. The patient is started on anticoagulation, but then needs an invasive procedure about more than 12 weeks after they had the stroke. So the question is, how would you manage this patient's warfarin perioperatively? So these are the choices, and we'll ask for a show of hands for each one. Who wants to calculate the thromboembolic risk with the CHADS-2 VASC score divided by 365 and determine the risk per day off anticoagulation? Who's doing that? Everybody thinks about it, but I don't think anyone does it. Who wants a bridge with low molecular weight heparin? Show of hands. Not many.
Few hands.
Who wants to interrupt therapy without bridging? All right. And who wants to continue warfarin without interruption? Well, this is an invasive procedure, so don't do that. All right, so the audience is pretty much in tune to what's going on here. Well, when you consider what to do with a patient on anticoagulation perioperatively, there's a balance between bleeding if you continue the drug and thromboembolic complications if you stop the drug. And the question is, what do you stop? When do you stop it? Do you need bridging? Well, if you go back to the 2012 CHEST guidelines, this is looking just at the segment for atrial fibrillation. You can see there's actually a misprint that's greater than 10 on the high risk. They divide it into 3 groups based on your annual stroke risk. Low risk is less than 5%, moderate is 5 to 10, and high risk is actually greater than 10. Our patient had a CHADS-2 score of 4, so they say individualize. If you want to bridge, you can bridge. If you don't want to bridge, you don't have to bridge. They gave you the option. That was 2012. 2015, the Outcome Registry for Better Informed Treatment of Atrial Fibrillation, the Orbit AF registry. This is 7,300 patients on anticoagulation. 2,800 patients had to stop it for some reason. They underwent a procedure. About a quarter of them were bridged, most of them with low molecular weight heparin. What did they find? They looked at MI, systemic stroke, stroke or systemic embolism, cause-specific hospitalization, bleeding, and death. And what they found, unexpectedly, was that the bleeding was more common in the patients who were bridged, 5 versus 1.3%, and the composite endpoint was also higher, about twice as much in patients who were bridged. This is what the numbers look like. For specific cardiovascular events, it just missed statistical significance, but you can see there were increased bleeding events and an increased overall composite risk. So they concluded that the data did not support routine bridging. So maybe this is something we should think about and maybe not do. So this is the question, to bridge or not to bridge? This has been an ongoing issue, an ongoing question, and we always have good intentions. We're trying to minimize the fact that a patient's going to get a stroke. We think we're doing well, we're trying to do right for the patient, but sometimes in the end, things don't work out exactly as we thought. So, should we bridge or not? Well, we have an answer. This is the BRIDGE trial, finally came out last year in New England Journal, randomized double-blind placebo-controlled trial. It took them at least 5 years to get 1,800 patients, very slow recruitment. There were equal in groups in terms of bridging or not bridging. And it's important to know who was in the trial and who was excluded. So the exclusions were patients who had mechanical heart valves, patients with recent stroke or systemic embolism, TIA, or bleeds, creatinine clearance less than 30, thrombocytopenia with a platelet count less than 100,000, and anybody undergoing cardiac, neuro, or spine surgery. So you could have valvular AFib, but you could not have a mechanical heart valve. The protocol was similar to what we use. Stop about 5 days before. After 2 days, you start the bridging agent, which in this case was dalteparin or placebo. They stopped it a day before surgery, and they restarted it anywhere from 24 to 72 hours post-op, depending on the bleeding risk. What did they find? Arterial thromboembolism. Event rate was low and no different between bridged patients and non-bridged patients, but major bleeding was significantly increased, 3.2 versus 1.3% in patients who got bridging anticoagulation. This is what the numbers looked like. They looked for superiority as well as non-inferiority. They couldn't get superiority for no bridging, but it was non-inferior to the bridging regimen. However, it was superior not to give bridging for major bleeding and also for minor bleeding. So the conclusion from this trial was that foregoing bridging anticoagulation was non-inferior to bridging with low molecular weight heparin for arterial thromboembolism. And it was also associated with a decreased risk of major bleeding if you didn't bridge. Now, it's important to know who was in the trial. So let's go back a step, look at the CHADS-2 scores for these patients. And in our case, the patient had a CHADS-2 score of 4. So there were a couple of hundred patients in that group. I feel perfectly fine not bridging this patient. I think we have enough evidence. I would say you do not have to bridge anybody with a CHADS-2 score of 4 or less. However, when you move into the higher risk, 5 and 6, then you only have 8 patients with a CHADS-2 score of 6, 50 or so with CHADS-2 of 5. So there are some limitations in terms of whether you feel confident not bridging. Personally, I won't bridge any of these patients. And if you come to tomorrow's debate, I'll tell you why. All right. Now, what if instead of a stroke, the patient had a DVT, also needs to have an invasive procedure? Will you bridge this patient or not? Will you put in a filter? So who wants to put a filter in this patient? We don't have many people doing filters. Bridging with low molecular weight heparin with a DVT 3 months ago, more than 3 months ago. Okay. Interrupt oral anticoagulation, but no bridging. A little bit more. Continue oral anticoagulation. Again, it's an invasive procedure, so that's out. All right, back to the guidelines again from CHEST in 2012. This is looking specifically at patients who had VTE as opposed to the AFib. Again, they divide them into 3 groups, low, medium, and high risk for recurrence. Our patient falls into that intermediate group again with an acute VTE more than 3 months ago, but not having any of the other risk factors. And this is one that they would say, again, bridge on an individual basis. So we do have some evidence now. This is a paper that came out last year that looked at bleeding, recurrent VTE, and mortality during warfarin interruption. It's a retrospective study from the Kaiser Group, 1,800 procedures, 1,100 patients on warfarin for secondary VTE prevention. What did they look at? 30-day outcomes were clinically relevant bleeding, recurrent VTE, and all-cause mortality. And what did they find? For clinically relevant bleeding, they found, again, as expected, the risk is higher if you bridge patients, and it was statistically significant. However, the risk of recurrent VTE was no different. So this is similar to the AFib group, where there was no difference in getting a clot, but there was a higher risk in bleeding. So they concluded that bridging therapy was associated with increased bleeding and may not be necessary for most of these patients. Now, these are VTE prevention patients. Again, I caution you, there is a limitation. If you look at the highest risk patient, and these would be people with a VTE in the last 3 months, there's only 57 patients in that group. So I might be a little bit cautious, but there is some other evidence from a previous study also suggesting that maybe we don't even need to bridge these patients as well. Okay, let's move on to a patient who now has a pulmonary embolism. This is a high-risk patient, severe symptomatic PE. The question is, can you make that patient better? Can you prevent the recurrence of PE by adding a retrievable filter on top of the anticoagulation? So it's not somebody who can't be anticoagulated. It's in addition to anticoagulation. This is the PREPIC 2 trial. And what they found basically was that there was no difference in event rate and no difference in anything else at 3 months or at 6 months. However, there were actually a few more events, and the events were fatal if you happen to look at them, in the patients who did get the filter. So quick take on this, their conclusion was in high-risk patients with severe symptomatic PEs, the addition of an IVC filter on top of anticoagulation didn't do any good and probably is not something that we should consider doing. Back to the patient. The patient had an idiopathic DVT instead of a PE. Should he be screened for occult cancer as a cause of the DVT, and with which tests? Who wants to do CT scan of the chest, abdomen, and pelvis? And somebody's doing it out there. Come on, all right. Who wants to do just age, gender, appropriate cancer screening? Well, we're doing that anyway. Who wants to do both? Who doesn't want to do anything? All right. Okay, so this is a New England Journal paper looking at screening for occult cancer in unprovoked clots, and it's a multi-center trial out of Canada. They had 2 groups. The first one, what they called limited screening. This is something that we would always do anyway. Your basic history and physical, your CBC and comp, a chest x-ray, and age and gender specific screening. So you can do a breast exam and mammogram, you do digital rectal exam and PSA, and depending on age, a colonoscopy as well. The limited plus group did that plus a comprehensive CT of the abdomen and pelvis. This included a virtual colonoscopy, gastroscopy, pancreatography, and bladder imaging, and in some of the patients, they had chest CTs as well. 854 patients with cancer. What did they find? 14 in the limited group, 19 in the limited plus. 4 cancers were missed in the limited group, 5 were missed in the CT group. There was no difference in terms of time to the diagnosis of cancer or cancer-related mortality. A caveat here again, a limitation, they had a lower incidence of cancer in this trial than they had previously reported, and it was about 50% less. So instead of 10%, they were down around 4%. So maybe you can't be as confident as you would like to be with a higher incidence of cancer. But their conclusion was that the addition of an abdominal pelvic CT to routine measures in patients with unprovoked VTE didn't provide a clinically significant benefit. So they're not recommending it. All right, quick break. We now have a new code for hospitalists. We're not sure what to do with it yet. We'll be talking about that tonight. And the ICD-10 has now been around for the last year. Let's have a little pop quiz. Know your ICD-10 codes. They have a code for everything. All right. Anybody from the Midwest, farmers out there, W61.33. Anybody know that code? Just call it out. Pecked by a chicken. All right. I'm down in Miami vacationing, V91.07. Anybody know what that is? Burn due to water skis on fire. And finally, we're in San Diego, V94.810. You're out on your boat. You get into an accident with military watercraft. They have codes for everything. You just have to look them up. Okay, let's get back to reality here. 75-year-old woman, swollen leg, no past medical history, no VTE risk factors. The exam is notable only for swelling of her leg and superficial varicosities. So the question is, what would you do to assess her for a DVT? All right, who wants to use a clinical prediction rule like the Wells criteria? Nobody wants to use Wells criteria? All right, who wants to order a D-dimer? Well, we're not doing anything. Doppler ultrasound of the leg? Of course, everybody does it right off the bat without using the first two. And how about just starting anticoagulation? This is a high-risk patient while pursuing the workup. Yeah, so basically you're saying C. Well, it's really an unfair question because I didn't give you enough information. Would your approach change whatever you picked if she presented to the office as opposed to the ER or was an inpatient? And what if the patient had chest pain or shortness of breath? Would that change your order and selection here? So this paper is looking at the prediction, the performance of the Wells score for DVT in the inpatient setting. And this is a problem that I've seen a lot with my residents all the time. They're always using the clinical prediction rules. However, they don't know that they've never been validated in the inpatient setting. So this paper was a prospective trial in an academic hospital, and they had the person who was ordering exactly what you ordered, which was the ultrasound of the leg, put in what they thought the Wells criteria score was. And what they found, the patients who had a low pretest probability actually had almost a 6% incidence of a proximal DVT. I don't consider that low risk. And if you look at the ROC, the number is 0.6, which is not much different than a coin flip. So they concluded that the Wells score performed only slightly better than chance. You need to couple it with a D-dimer, but a D-dimer in the in-hospital inpatient setting is not good either, and the majority of them will be positive. And they said that the Wells criteria is not sufficient to rule out a DVT or to influence management. But I guess nobody in the room was using it anyway. You were going right to the ultrasound. So what? Okay. Now what if she had chest pain or shortness of breath instead of a clot in her leg? And Nick was actually on this ACP committee for clinical guidelines looking at suspected acute PE, and this is best practice. And they came up with a number of high-value care recommendations. First is to use validated clinical prediction rules. So as I said, the Wells criteria was not validated for inpatients. Second, if you're low pretest probability and new criteria, pulmonary embolism rule-out criteria that they came up with, don't do D-dimer or imaging. That patient's very low risk. You don't have to do anything. Unfortunately, we see very few patients that have those characteristics. If the patient is in intermediate risk pretest probability, or they're low probability but they didn't meet that rule-out criteria, then they recommend doing a high-sensitivity D-dimer. When you use the D-dimer, you have to adjust it for age. So in patients who are over 50, it should be age times 10 nanograms per ml for the upper limit of normal. So 500 is no longer the upper limit of normal for the elderly patients. No imaging studies if the D-dimer is below that cutoff. And if you're high test probability, don't even get a D-dimer, go right to imaging, and they recommended the CT angio over VQ scanning. And they came up with an algorithm, and this is what you can see. Basically, the differences are the use of the pulmonary embolism rule-out criteria and the age-adjusted D-dimer in the middle. But this has not yet been validated as far as I know. All right, the ongoing VTE saga. Patient was diagnosed with a PE, started on low molecular weight heparin and then given dabigatran, and 2 months later she's injured in a motor vehicle accident and requires urgent surgery for bilateral lower extremity fractures. her last dose of dabigatran was 6 hours ago. Which of the following would you recommend? Who wants to do hemodialysis? Nobody? Fresh frozen plasma. How about 4-factor PCC? A few. Idarosizumab? A bunch. And Dexanet? No. Okay, so the few people that voted, most of you got it right. This is idarosizumab for dabigatran reversal. Came out in the New England Journal last year. And this is actually a clinical study, not laboratory study. And they had 51 patients with serious bleeding who needed to have that bleeding stopped, the anticoagulant effect reversed, and another 39 patients who were going for urgent surgery where the surgeon said he wanted that reversed before he could operate. The two tests that are usually used to gauge the effect of anticoagulation with dabigatran, the dilute thrombin time and eccrine clotting time, things that we don't normally have available to us on a routine basis, were normalized in over 90% of the patients. They also measured dabigatran plasma level, and they found that it was less than 20 nanograms per mil, and that's considered to be subtherapeutic. The median time to cessation of bleeding was about 11.5 hours, and in those patients who went to surgery, about 92% were felt by the surgeon to have normal intraoperative hemostasis. Now, this is a high-risk group, very high-risk population, and the drug basically is going to start causing clots. You want them to stop coagulation? They will. 5 thrombotic events, 18 deaths in this population. However, they still concluded that idarosizumab rapidly and completely reversed the anticoagulant effect of dabigatran in over 90% of the patients without significant safety concerns. Remember, these patients were in trouble anyway, so they are likely to get clots and have other problems. Well, what if the patient's on one of the 10A inhibitors instead, apixaban or rivaroxaban? Well, that drug doesn't work. That's specific to dabigatran. So here there's a paper at the end of last year, also in the New England Journal, and Dexanet alpha for the reversal of the 10A inhibitors. And what you can see, there's 2 sets of graphs. The top 2 graphs are after a bolus of the drug. The bottom 2 graphs are a bolus followed by an infusion. And the drug is in red, the control is in black. And you can see that this drug, Dexanet, reduced the anti-10A activity, decreased unbound fraction and concentration of the drug, and restored thrombin generation in the majority of the patients. Certainly much better than what you see in placebo. So they concluded that this drug rapidly and completely reversed the anticoagulant effect of apixaban and rivaroxaban. Those were the 2 that were tested. But this is in older, healthy patients. This is not clinical studies like the last one where they had bleeding patients or patients going to surgery. This is in sort of healthy volunteers. But they also have other studies that they're working on now. And this drug may be approved in the next 3 to 6 months or 6 to 12 months. So just be aware of that happening for these 10A inhibitors. And the last 2 articles I'll talk about are in cardiology. We get a lot of patients admitted for chest pain. A lot of times we don't think they need to be in the hospital. And we have the OBS units. How can you get these patients out even faster? This is looking at adverse cardiac events in patients who had chest pain at hospital admission. 45,000 patients. They were looking at patients who had 2 negative troponins, normal vital signs, and a non-ischemic but interpretable EKG. 11,000 met criteria. They had a primary outcome that was a composite of life-threatening arrhythmias, inpatient STEMI, cardiopulmonary arrest, or death during hospitalization. They only had 20 patients, 0.18% of the population, and after excluding people that had abnormal vital signs and EKGs that couldn't be interpreted, there were only 4 events out of 7,000 patients, 0.06, and 2 of these were iatrogenic. So they said that short-term clinically relevant adverse cardiac events were rare and that maybe routine inpatient admission is not a beneficial strategy. So these patients are basically ruled out before you get them. You should consider sending them home. No testing. And this is now looking at diagnostic testing strategies in patients that came in with chest pain to the ED. And they want to see what happened down the road depending on your testing strategy. This is a different group. This is privately insured patients. And they looked at 5 strategies. No test at all, exercise EKG, stress echo, myocardial perfusion scintigraphy, or coronary CT angio. 421,000 patients, 1/3 of them were tested, and 2/3 did not get any test initially, which is nice to see because I think we do too many tests. Only 0.1 and 0.3% of patients were hospitalized with an MI during 7 and 190-day follow-up. And those patients who did not undergo initial non-invasive testing were no more likely to have an MI than those patients who did get a test, And those patients who did get a test were more likely to undergo cardiac catheterization and revascularization procedures, but without a concomitant improvement in the odds of experiencing an MI. So they did more tests led to additional tests and interventions without any benefit. So they concluded that patients with chest pain evaluated in ED who did not have an MI are at very low risk for experiencing MI during subsequent follow-up, regardless of your initial testing strategy, and it seems to be reasonable to defer testing in a number of these patients. And with that, I'll turn it over to Nick, and we'll change gears.
Okay, thanks, Steve. A few more cases. We're in the home stretch here, and I think we're going to try to trip you up. So, 60-year-old man presents with right renal colic. He's scanned in the ED, has a 4-millimeter proximal ureteral stone associated with some right hydroureteronephrosis. In addition to analgesia and IV fluids, what can you do to enhance stone expulsion? He didn't pass it. He's got to get admitted, maybe have a procedure done. So, who wants to give tamsulosin, the alpha blocker smooth muscle relaxer? That's right, it's in the guidelines, it's in up to date. Good. How about nifedipine? Also in up to date, the smooth muscle relaxer. How about N-acetylcysteine? Anyone want to give N-acetylcysteine? I put that in as a distractor because sooner or later it's recommended for everything, right? And how about tadalafil? Anyone want to give tadalafil? Your mind's in the gutter, Lenny. I saw that. I saw you raise your hand. All right. So file this under things we do for no reason. This was the SUSPEND trial, spontaneous urinary stone passage enabled by drugs. Randomized placebo-controlled trial over 1,100 patients, and they were randomized based on stone size and location to either placebo, tamsulosin, or nifedipine. And they looked at time to stone passage, need for analgesia, and a few other endpoints. And bottom line, what they found is no benefit. There was no benefit from tamsulosin or nifedipine. How does this happen, you may say? I mean, this rejects what we all thought was a safe and effective practice. So this is, in the evidence-based medicine world, there's this ongoing debate. Should a single, large, high-quality, randomized controlled trial define our practice, or a meta-analysis which rolls up a bunch of smaller trials? And that's how these treatments got embedded in guidelines. Smaller trials hinted at benefit, rolled into a large meta-analysis, thus our treatment. But the SUSPEND trial may reverse that. Okay, next case. A 48-year-old woman with a history of alcohol addiction presents with jaundice and acute liver failure. Her discriminant function is 61, MELD score is 21. So sick lady, right? This is mortality in the 40 to 50% range. In addition to nutritional support and the alcohol withdrawal protocol du jour of your hospital, which of the following should you do? Who's going to give prednisolone to this lady? Okay, yeah, that DF is pretty high. How about pentoxifylline? Anyone give pentoxifylline? Okay. And how about GCSF and Epigen? Anyone want to give that? If time permits, ask me why I put that in as a distractor. And D is the right answer. Call your hepatologist because, as you're going to see in a minute, there's really nothing to offer these people. So the STOPA trial, steroids or pentoxifylline in alcoholic hepatitis, was published last year. And they randomized over 1,100 patients, just like the case we presented to you, to either prednisolone, pentoxifylline, both, or neither. They looked at mortality at 28 days, 90 days, 1 year. And what they saw was pentoxifylline didn't help at all. Prednisolone seemed to reduce mortality at 28 days, but it didn't achieve statistical significance. And that benefit, any benefit that may have been there, was gone at 90 days and at 1 year. Now, closer inspection of the, let's see if this blows up. Yes, closer inspection of the patients that were enrolled here, about 10% of them had sepsis upon enrollment, and another 6 to 8% had a GI bleed. Patients we probably wouldn't give steroids to if we knew that. So putting this into practice, alcohol abstinence and nutritional support are probably all we really have to offer these people. Prednisolone, maybe it's going to buy us some time in the non-septic, non-GI bleeding patient. Time to what? I don't know what that next treatment would be, what the bridge is. 2, look for ELAD. Enrollment in your community. What is ELAD? ELAD is, in essence, it's a dialysis for the liver. It's still investigational. I'm not promoting it. They have a booth out in this convention center, and you'll see their advertisements actually in JHM. And I threw bullet number 4 in. That's an older study from 2011 showing that N-acetylcysteine reduces infection in alcoholic hepatitis, just because we really have not much to offer these people. Again, things we do for no reason. Okay, here's a great case. 60-year-old Asian man with type 2 diabetes, hypertension, undergoes outpatient knee arthroscopy that he probably didn't need. He's on lisinopril, atorvastatin, metformin, and canagliflozin. After an uneventful procedure, he's brought back to the recovery room. His vital signs are stable, his blood sugar is 160, but he's having post-op nausea, vomiting. The anesthesiologist orders some ondansetron. He still has post-op nausea, vomiting. That's when you're called. So you call to the recovery room. Which of the following would you order next? Does anyone want to give prochlorperazine? Anyone want to give metoclopramide? He's a diabetic. Maybe he's got gastroparesis. How about insulin and IV fluids? Anyone want to give insulin and IV fluids? Sugar's only 160. No takers. We got him on this one, Steve. Anyone want to order lactic acid? He's on a biguanide, right? Metformin. All right, so what we should have done is we should have given insulin and IV fluids, because what this guy had is euglycemic diabetic ketoacidosis. And it's a recognized complication now of the sodium glucose cotransporter 2 inhibitors, SGLT2 inhibitors. Now, the reference that we're giving you here is of only 13 cases, but another 20 cases were reported by the FDA in May, and then on December 5th, they released another a report of 73 more cases. The equivalent of the FDA in Europe already reported over 100 cases of this complication. It's important to recognize this emerging complication because these patients had terrible things happen to them. They had persistent anion gap acidoses. They were brought back to the OR for laparotomies. They were dialyzed. They were intubated. So what is SGLT2 and why do we inhibit it? So take a step back. Glucose is filtered through the renal tubules, and then it's reabsorbed through SGLT2. If we block SGLT2, glucose comes out in the urine, my blood sugar goes down. Calories go with it, my weight comes down. It also blocks proximal tubular reabsorption of sodium, so my blood pressure comes down. I mean, this unique mechanism of action makes these drugs desirable for type 1 and type 2 diabetics. So there are 6 of these agents, 3 approved by the FDA for use in our country, but for use in type 2. But because of their mechanism of action and social media, they are being used more and more off-label in type 1s, and these reports include type 1 and type 2 diabetics. There's a common theme to all these patients. There was a decrease in carbohydrate intake because they were NPO for surgery. They had an intercurrent illness. Sometimes alcohol was involved. There was a decrease in insulin for the same reasons. They cut their insulin down because they were feeling sick or they were going for surgery. There's an increase in counter-regulatory hormones because of the stress of surgery, stress of an illness, and their blood glucose was only mildly elevated. So you check their sugar, it doesn't look that bad, but the liver is not seeing enough insulin for that glucose, so it starts to oxidize free fatty acids. So the take-home message is here. Anyone on an SGLT2 inhibitor that does not feel well, check ketones, serum or urine dipstick like we did in the old days. Stop SGLT2 inhibitors 3 days before a procedure. Some of these cases, they stopped it 1 day before the procedure, and it wasn't long enough. They still developed euglycemic DKA. And if someone comes in emergently on one of these drugs and has to be NPO, consider putting them on an insulin dextrose drip. All right, so take-home messages. Things we could start doing. Start using steroids in severe community-acquired pneumonia. Look for the results of the ESCAPE trial later this year or early next year. Start using high-flow oxygen via nasal cannula for severe acute hypoxemic respiratory failure. Start using endovascular therapy for stroke patients that meet the revised focused update of the AHA-ASA criteria. Start using the pulmonary embolism rule-out criteria in low-risk suspected PE patients and use an age-adjusted D-dimer in those patients. Start checking ketones on patients taking an SGLT2 inhibitor that are not feeling well.
I always get the things that you don't do. Stop giving oxygen to normoxemic patients with a STEMI. Stop bridging AFib patients for the most part. If you don't buy the 5s and 6s, at least from 4 down, don't bridge them. Stop using filters as an adjunct to anticoagulation in high-risk patients. Stop searching for malignancy after an idiopathic DVT. Stop using calcium channel blockers and alpha blockers to enhance stone expulsion. Stop using patoxyphylline or steroids in alcoholic hepatitis. and stop the SGLT2 inhibitors 3 days before surgery.
Okay, things to consider. Consider endovascular therapy for stroke patients that do not meet the updated guidelines. And what we mean by that is a lower level of evidence. So the guideline I showed you, that one pager, that was a level 1 Class A evidence for those that had clot in the ICA or M1 branch of the MCA. But they do recommend for highly selected patients that have clot in the M2 branch, the M3 branch, or the posterior circulation, we may consider endovascular therapy for those patients. Consider not bridging intermediate risk patients with VTE, and we gave that only a consider because of the retrospective nature of the data that Steve presented to you. And consider early discharge and deferral of non-invasive testing in low-risk patients with chest pain.
Okay, and in the future, near future, watch for euglycemic ketoacidosis in patients on SGLT2 inhibitors, and watch for FDA approval, hopefully, in the near future, for a new reversal agent for 10A inhibitors. And most of all, I think you need to watch for this guy. He comes in too frequently. All right, I'll last take some other ICD-10 codes that you might consider. You haven't seen these? Whole slew of them. And otherwise, I hope you enjoyed what we presented. I hope it was useful information. And thank you for your attention. See you next year in Vegas.